Sir just mentioned about the nasal conformer. So I just like to know how long would you like to keep the nasal conformer, because a few of my patients I have seen after doing it, even if I keep it for like 3 weeks, 4 weeks, 5 weeks, still it collapses after that. So
the recommended duration for using the nasal conformer is around 6 months, but we tend to use it for a longer period of time in most of our patients, at least for 8 months. Sometimes it becomes loose because the child grows, so you may have to go in for the next size. And compliance also is a problem because they tend to breathe during their breathing process, it comes out. But these days you get conformers with a special extension, so you can tape it.
So I want to ask about when you want to lengthen the columella, especially cleft cases. So any different incision transcameral?
See, most of the cases that we do in order to lengthen the columella in the lip repair, we do what is called as a molars modification. So molar modifications will give you or facilitate adequate lengthening of the columella. That's the basic purpose of that particular modification to the Millard's original repair.
Point of view,
the collector patient have a deficient of not only the cartilage, size, mass, content, volume, even all tissue have a lesser content than the opposite contralateral side. How will you address these volume?
What's the last thing you said?
Even cartilage, muscles, soft tissue have a lesser content than the contralateral side of the nostril. Collector patients, unilateral collector patients. How will you address that? Make a content equal more aesthetic?
As per the literature, there is nothing to suggest that there is volume deficiency. In terms of volume, there is no deficiency. Cleft is basically the tissues are displaced. Okay, there is nothing. Maybe in bilateral cases, you would see some amount of volume deficiency with regards to prolapse, not otherwise.
but I read in a Dallas book, I think, very famous book.
There are a lot of things. What
This book, they are mentioning it, so that's why I am not that much of experience.
Okay, we'll start with the interrogation. Thank you, sir.
Okay. So time to increase your calories because she'll be throwing calories on you. Actually, people are not answering because they don't want to increase their calories. Everyone is calorie conscious. You should throw dumbbells on them. So yes, very simple. We'll throw 100 chocolates now. Name the non-paired structure in nasal anatomy. Wrong. Yes, septum is the right answer. So septum is actually comprised with cartilaginous septum and then bone, the bony septum. Okay, so both are together called septum. Okay, so fast. Who will tell what is the underlying structure below this orange thing? No, you are wearing orange. I will not give you. Somebody from behind. Give me, ma'am. No. Somebody last girl, white shirt. In the middle.
Whoever is wearing a
Jaldi, खड़े हो गए, जल्दी बोलो, जल्दी. Don't know.
Nobody.
So nobody was listening my lecture. Okay. This is the only place, actually in picture or no, people sitting in front are actually less privileged. Here I think people sitting in front are more privileged. So reverse of theatre hall, people sitting behind are paying more and not listening only. Okay, somebody from last, next question. Okay, so this is upper lateral cartilage, corresponds to upper lateral cartilage. Okay, so this is a case. So see it and tell me which location the deformity is. If you can relate it with the underlying anatomy.
Between the bone and the cartilage. Anyone from this side behind?
No. Front ones, please keep quiet. Let others give up.
Keystone area.
Raise your hand.
Just stand up. Keystone area.
No.
Okay, anyone here? Radix is shifted towards left.
Yeah, it's correct. It's more in the just below the keystone area. Yes. And it is in the upper lateral cartilage area. Okay, keystone will be at the junction of nasal bone and the upper lateral cartilage. where the normal hump is there. Okay. One more case. So there are 3 views. So I'm not asking the treatment. You have to just diagnose which all area the problem is. Okay. I said upper third, middle third, lower third. Okay. Upper third, nasal bone, middle third. This will help you all your life. If you are assessing, you have to assess with the underlying structure. So upper third is nasal bone, middle third is upper lateral cartilage, lower third is your lower lateral cartilage. Only middle third?
All three.
Huh?
Middle and lower third.
Okay. What? Can you see some difference here also?
All three.
Yes.
All three.
Yes. Mostly all 3 and more prominent in the middle and lower third. So until you actually know what you have to correct, see, open and sit. I have done that. Because we learned doing open rhinoplasty, but we never knew open access we were knowing. We never knew what rhinoplasty means, how to correct it. So we used to open and then see अब क्या करना है. Okay. So now you have got these programs happening where actually you learn beyond just giving incisions. Okay. नहीं सर आपको सवाल अलाउ नहीं. अच्छा हाँ पूछिए. हाँ वही तो.
I want to ask. Okay, now he is speaking a lot about upper lateral cartilages. So when we do a cosmetic rhinoplasty, is it very important that we have to open up the upper lateral cartilage every time separate? सवाल किसको है? तो फिर आप क्यों जवाब दे रहे हो? Is it important that we have to always open up the upper lateral cartilages and then we suture it back?
Answer.
जिसको बोलना है प्लीज खड़े होके बोलो चलो.
No, only there
Whoever
is a
stands
problem.
first gets to answer. There is a deviated
Catch the mic.
If there is deviated nasal septum, then we have to open up and then close it. If there is no deviated nasal septum, then it's no deviated.
See, what I believe is if you're talking about rhinoplasty, there has to be a septorhinoplasty because you have to, Indian noses are generally weak. As I told you, the cartilage, if you go into literature also, the caudal septum is less than 1 millimeter. So if you're looking for a proper tip support and everything, then you have to open your septum. So once you open the septum to get better access, then you have to cut the upper lateral cartilages. But if you can do without cutting, then it's again what you call this preservation rhinoplasty. So it's not necessary that you have to cut, but depending on your comfort level needed and what kind of surgery you're looking at, the problem that you have, accordingly then you decide. It's not necessary that you always open the upper laterals.
So can we use a spreader graft on unilateral side to correct the deviation?
That's what we do.
So the answer is again what sir asked. Answer is same. If you have to access the middle and upper third, then only you have to think of cutting the upper lateral cartilage. If you are just working on the lower third, no need to cut upper lateral cartilage. And if you are planning just an augmentation, then also you just need not to touch because that is damaging your internal wall. Okay, this is very, very important. If you cut the upper lateral cartilage, don't get the angle right or you reduce the angle, then patient will have breathing problem. It was not there before, it will happen after your procedure. So this is again one case, very simple trauma case as a maxillofacial. This is the most likely rhinoplasty case you will get it. Okay, post-traumatic nasal bone fracture recently, 6 months old. Okay, so what do you think? Where is the problem now? Exactly. So here you need not to do an open rhinoplasty. Okay, you just do a nasal osteotomy, small stab incision, just do a osteotomy and correct the nasal bones. That's all is required in this case. Okay, so here you don't need to give any incisions, and that's how this was corrected. Okay, this is one case. Rahul will ask the question.
So what are the problem findings? What are the problems in this from the lateral?
Tip
is not sharp. Somebody stand up and answer please. Rounded nasal tip.
Yes, good.
Yes.
Tip.
Dot. This is so difficult to throw. Sorry.
Rounded nasal.
Take chocolate.
Rounded nasal tip. And
Let's define suprachiasmatic point.
yes, suprachiasmatic point is not there, correct? Okay, correct. Spell treatment not there. Yes, alaflaric, yes, and yes, who said that? Columella show. Very good observation, ma'am. Protein chocolate done चाहिए वहाँ पे. वो columella show पकड़ लिया. बहुत ज़्यादा हो गया.
I'm seeing her calling me.
Let's columella show, right? And
Paranasal depression.
phalanx and dorsal.
Paranasal depression.
Because the nose is not projecting well. When there's less projection, there's again deeper nasal level fold.
Slide change. Schedule.
Okay, so this is the one which I showed you before also. So here you see what we've done. We've increased the height from the radix, okay, along that upper lateral going up. She has a good superative breakpoint there. All the cartilage, you see the typical angle which I'm making. You see in the drawing there, the lower laterals are pulled out anteriorly. The intermediate crura is high up, and the slight curve of the medial crura to give you the proper hip angle. So I've written there. So osteotomy, nasal bone bridge pushed up. There's an inlay cartilage graft. There's pedagraft to strengthen the cartilage, septal cartilage, because the septum is going to hold the entire cartilage which is sandwiched inside. And then you've got your upper lateral cartilage which are pushed, upwards. The alar cartilage are being pushed upwards. Supracolumnar strut graft has been given to give you a little bit of more, columnar show.
So what kind of osteotomy you did in that case, the first one? What kind of osteotomy?
It's a little advanced. It's a U-shaped osteotomy. Okay, so it goes into the entire upper wall is basically broken up to push it up. So it's not a standard osteotomy. It's a little different. And there's a very good article by Dr. Dean Todd. That's the only article on push-up rhinoplasty actually. So I'll put up in a group. It's a very good article. Okay, so what are these markings that I made? What is that called? That angle which I made, what is that area called as? I mentioned it in the...
90 to 110, 100 to 110, 90 to 100.
And what is it called? No? Resting angle. Yes, the resting angle. So it's resting angle, where your lateral curve resting. So resting angle means where your lateral crura is resting. Okay, so the resting angle has to be 100, 110. And what is that line, that straight line, the tip, which I made? So what does that signify? That line on the straight line, on the tip? Yes, so that how much minimum you should leave in that case? The width. That also I mentioned with the scale. There was a slide with the scale. Yes, 8 to 10 millimeters. There. Just miss. Don't give an open angle, then you have a pointy tip. Then you have Pinocchio nose. Many people do that. You get a Pinocchio nose. You don't want a Pinocchio nose. No personal talks. So you always keep the angle open, okay? So it's only at the cephalic end where you've stitched it to get the domes together. But your caudal end of the intermediate crura have to remain open because you don't want a pinched out Pinocchio type of a nose. You want a little flatness in this part. It should be a little flat. So that's why you keep it open. In natural nose anatomy also, I showed you one picture before and after rhinoplasty, right, in the lecture. So there also if you see a natural nose, your medial crura is never together with each other. There's always a space between the medial crura. And even if you see intermediate crura in a natural unoperated nose, it's again there's a space between them. They're not joined together. So in the surgery also, you try to maintain that. Two reasons. One, you're trying to maintain the natural anatomy. Second thing is, even I get revisions of my own cases. Sometimes you have to revise them. Sometimes patient is not happy with the tip. Sometimes scar happens, tilting. So now when I approach my nose to open the nose, I just have to follow how I used it before in a primary rhinoplasty. So it's a very clean field that I can just open it, not struggling to separate the two medial cruras. Right? So you try to preserve anatomy as much as possible and reinforce it. So that is how you do a proper rhinoplasty.
One question, sir. Here, can you tell us how many grafts at what position you have used for this particular case?
You can see here at the dorsal part, there are two cartilages. Can you see those two cartilages there?
Can you
okay,
use it?
So here, what I close it is distorted. I put two spreader grafts there. Oh, it will not get scratched now. It will get scratched. Okay. So there are. This is your septum. Okay. This is your upper lapidus on both sides. So this is your spreader graft. So I generally always put spreader graft if I'm opening the upper lateral cartilages. So those two on top are the spreader graft. Now down here I've got three grafts in this part. One is that which I showed in one picture, that caudal septum. I'll be putting one graft to strengthen the caudal septum because caudal septum sometimes can buckle and then your nose tip can go left and right. So you strengthen your caudal, so that's in the caudal part of the septum. Then at times my workhorse is generally the septal extension graft, which I'll be mobilizing with the caudal septum. So that goes, you see this cartilage here where this is being held on. So this is my septal extension graft, which is coming from the septum. And then, as I told you, in this case, sometimes I need to show more of the columella show, right? So in that case, then I'll be putting one, columella strut here. Now, columella strut again, I won't be suturing it with the, the caudal end of the medial crura. What I'll be doing is I'll be taking the bite from the posterior part. A lot of times I use the Pitangaya ligament. So Pitangaya ligament is basically the tissue which is attached towards the medial end, or the cephalic end of a medial crura. So with that, I'll be suturing and giving mattress, horizontal mattress behind it. So this thing remains open. Okay, so you maintain the open end. So these are the grafts placed there. Spreader graft, caudal septal batten graft. Then I put one septal extension graft. Then I put one columnar strut graft. Then regular normal stitches. Then sometimes I give a stitch between the junction of your upper lateral cartilage and the lower lateral cartilage to keep it there. The position I don't want it to go behind and overlap my dorsal bone. You don't want this cartilage to be here. If it's here, the nose will be broad. So you need to put it anterior to the anterior border of the upper lateral cartilage. So these are the maneuvers done in this particular case.
And then you cover this open loop, you put it fascia,
not necessarily. If it feels smooth, scarring in just form a bit of.
These all are costopundal, right?
No, these are septal cartilages. So from the septum itself.
Get this much of
Yes. In most cases, unless it's an augmentation case, you need extra cartilages. Otherwise, you get it from. So you have to plan it first. You have to always plan it. So when I was very new, so what I used to do is I used to take that suture wala plastic, that suture se I used to get plastic thing. So I used to cut there and I used to put it there.
That's the best thing.
Planning. I used to put it there, suture these cartilages and see how it looks. It looks good. Cut it. So it's like a template. So I used to do that earlier as a beginner. Now with practice, it starts to get in.
Any questions?
So in this you have mentioned that in the anterior part, septal extension, caudal and the columellar. So is it that three grafts you have put, septal extension, caudal and the columellar. So is it that in every case you would be doing, or there are very specific cases? Because when we are doing septal extension, do we always need a columellar is my question.
No, not necessarily. If you want to, see, there have been multiple articles which have come out of late. Okay, there's a very big article of 15 years of all different techniques that they have used. In that, they have come with an inference that septal extension graft is the most stable workhorse in a rhinoplasty for specialists for a tip. So a lot of time I do just Pitangaya repair. So that is basically I told you that we need the cephalic end of the medial crura. So that are stitches. So what it does is, because you're stitching like this, so it will push your columellar cartilages anterior to your septum because it's closed. This is your septum. This is your medial crura. If you stitch it like this, it will go in like this. And now when I'm stitching together, both sides will stay like this. So it's air of your, septum. So that
this is very, very advanced.